First of all, I would like to apologize with you because during this session you will be listening to me for a while because I'm going to give 3 presentations. 2 of them will be on behalf of my colleagues of the Technical University of Madrid. So this one is actually one of them. I'm going to speak on behalf of my colleague Matteo Pastorino, who is working in Perform project, which is a partially funded project by the European Commission, and it's focused on the Parkinson disease. So, first of all, for those of you who don't know about Parkinson, Parkinson disease is a degenerative disorder. It is a progressive disease that affects nerve cells in the part of the brain, which are called the basal ganglia and the substantia nigra. What happens with this part of the brain is that the nerve cells, the neurons, are affected and some of them die. And the problem is that these neurons are responsible of creating dopamine, which is a neurotransmitter that is responsible of starting the movement, the body movement. So what happens is that if these neurons die, no dopamine is created, and the patient has movement disorders. The causes are not known. Scientists think that there may be different genetic factors that affect a person to have this disease. For example, if your family had Parkinson's disease, you may develop it, you have more probabilities, and also different environmental factors, but the truth is that they don't really know currently the situation. So which are the symptoms? Okay, basically movement disorders. There are lots of movement disorders. Almost all of them are caused by this lack of dopamine, this neurotransmitter. But for example, the dyskinesia is a movement disorder that is caused because of the medication. So you take the medication and you may have this movement disorder, which is, I don't know if you may have seen a person with Parkinson's disease that sometimes they start moving like they can't control their body. This is caused by the medication. So we have bradykinesia, for example, which is the slowness of movements, akinesia, which is absence of movements, and we have the rigidity of muscles, the tremor, and finally the freezing of gait. So it is very difficult for them to start walking. Of course, there are also some cognitive and behavioral disorders. For example, dementia, depression, hallucination. The problem with depression is it is not really caused by the disease itself, but it's caused when they are told that they have the disease, so they get depressed. And the problem is that people cannot take the medication for depression at the same time that they are taking medication for Parkinson, because they are not compatible. So they first need to be cured from the depression, and then they can start thinking about treating Parkinson. So it's really complicated. And finally, they have sensory, sleep, and also emotional problems with the relationship with other people. They have problems with their voice because the muscles are affected, etc., etc. So the core of this work that I'm presenting now is the akinesia movement disorder, which is absence of movement. The problem is that any automatic movement or action, including gestures like blinking or swallowing, are limited and the frequency decreases. Although the elemental motor functions are continued, they can be performed voluntarily. The cause is the lack of dopamine, and the treatment is a medication which is called levodopa, which is used for most of the movement disorders of the Parkinson's disease. So in this graph, there is a representation of what happens when the patient takes the medication. So there are some phases when the movements are not controlled at all, and this is called the off phase. Then after a while that the patient has taken the medication, there is the on phase, which is where the medication can control the movements of the user. And then there are some peaks, which are called the dyskinesia problem, and this is when this is caused by the medication sometimes in later stages of the disease, of course. And physicians don't know how to avoid these peaks. They just need to adjust the treatment so that these peaks of movements are lower. So what happens today with Parkinson is that, well, the only thing that they can do, because the disease cannot be cured, the only thing that they can do is adjust the treatment so the patient feels better and the movements are as much controlled as possible. So they go to the clinic every 4 or 5 months, and the doctor asks them how are they feeling, what happened after taking the medication. They use some protocols. For example, this UPDRS, which is Unified Parkinson's Disease Rating Scale, which consists of some questionnaires and some tests that let the doctor have an idea of what's happening with that patient. But as I say, it is done every 4-6 months, and it's done in the clinic. And the problem is that, you know, that when we all go to the doctor, we all tend to say that we are better than we are. So this is a very subjective process. And the reality is that the doctor needs to imagine what's happening with the patient, but they don't have objective data. So how can personal health systems help in this sense? Well, technology can provide the support to the patient so that they are 24 hours monitored at home. So we provide the technology so that the movements of the patient are monitored all the day, and after this monitoring session, all the data goes to the clinician, and they have objective data to assess what is happening with the disease. And based on this data, they can adjust the treatment. So the objectives basically in short term will be this 24-hour monitoring, the detection of the on and off phases so they can adjust the medication. And another objective is also to know data about what the food intake of the patient, because it happens that if the patient is eating something that has lots of proteins, the medication may not work. So there are lots of problems related also with the food, and then the medication schedule, the dosage, etc. And in long term, the objective is to assess the therapy, analysis of symptoms, progression, and finally recognition of changes in the therapeutic response. So this is where this project comes. This European project tries to help in some way. This is the architecture of the system. It has been designed as a closed loop. Well, not really a closed loop, because when all the information reaches the physician, he takes the last decision. I mean, it's not an automatic process, but it starts with the 24 hours monitoring with different accelerometers that are placed in the body of the user. And these, besides other information about the food intake and the medication, are gathered, and then there is a patient profile that is built by the system. Okay, so each patient has a specific disease profile, and with all the data, they can assess the disease progress. So the system automatically suggests some treatment changes, but finally it is the physician who takes the decision. So this is the architecture a little more in detail. There are some wearable sensors, accelerometers, which send all the information to a logger that retrieves all the data from sensors. And after a monitoring session, the patient goes to his PC and updates all the data in the PC. There is a pre-processing of the data, and after that, all the data goes to the clinician that assesses the disease and decides what to do with the medication. So this is basically what I just explained. So here you have a representation of the sensors, and they are put in the patient like this. They are not very heavy, actually they are not heavy at all. And they also carry the logger in the trunk, in a belt. This is the logger, which retrieves all the data, and this is an example of one of the sensors, one of the accelerometers that the user may wear. This is the patient interface, which is used for the patient to enter data about the food intake and also about the medication that he took or not. So he indicates, the patient indicates whether they took their medication or not. It is used in a very big screen and with very big icons, so that patients that are moving under control, they can click the icons. It has drag and drop functions, and the look and feel was designed as the phone dialing pad, so it is easy for them to use, because a lot of people with Parkinson disease are elderly people. So basically the innovation consists on the continuous monitoring, the detection of all symptoms objectively, the early recognition of disease progression, and the prognosis of disease evolution according to patient characteristics. So the project has already performed different pilot sites with a lot of users in different phases according to the different phases of the development of the system. So starting with the data collection with Jiménez, which are the sensors, in order to design the algorithm with healthy and ill people. The second phase was data collection in a supervised environment to design the algorithm and train the classifier. Then data collection in an unsupervised environment, and finally the data collection for the test and validations of the algorithms to detect the symptoms. So some of the symptoms can be detected directly, continuously from the patient, and some others need to be assessed depending on the activity of the user. This means depending on whether the user is walking or not. So they depend on the activity, which are the three on the right. And all of the data are saved in a repository. So the focus of this work that is presented in this paper is Akinesia model, which assesses the amount of movement of the patient in space for any given period of time. This is how they designed the algorithm. Once they have all the signals, the three-axis signals of the accelerometer, they calculate the resultant in order to eliminate the position dependence of the sensors. And after that, they filter the signal, and they get only the lower frequency, because akinesia is related with the slowness of the movement, so they only need the lower frequencies. After that, the signal is split in 5 minutes length epochs, and they calculate the total amount of energy for each working sensors. And finally, the module is able to recognize automatically the sensor setting. So this is an example of a real data collection of a real patient. This was a 4-hour data collection, and from the results, the developers on the project decided that it is possible to discriminate the on and off phases of the user by assessing only the akinesia. So for the analysis of the results, two different scenarios are considered. There is a difference between when the user is walking and when the user is not walking. So the activity module is also has a role in this assessment. The graph on the left, where you can see where when the user was not walking, the green band is the one of the on phase, and the red one is the one of the off phase. And on the right you have the walking periods. So the global evaluation of both scenarios demonstrate that it is possible to discriminate between on and off periods. So just to conclude, this PERFORM project, and in particular this Akinesia module, is a useful and objective tool for the analysis in Parkinson disease patients. It is suitable for clinical practice because they have already tried in clinics with real patients and useful data has been retrieved. This tool supports health professionals in the diagnosis and follow-up of the Parkinson disease patient. They pretend to improve their quality of life by letting them stay at home and providing more data to the doctor to assess their disease. And as I just said, they think that they are able to discriminate this on and off basis. So the future work is basically a more exhaustive analysis using all the recordings collected during the pilot phases. They want to combine also the results of all PERFORM classifier outputs of all the modules that detects each symptom. And finally, they want to create a complete profile of patients. So I think that's all. If you have any questions.
Thank you very much. Anyone wants to ask something? Okay, so I will ask it. I was wondering, I assume that these sensors have to be wear on the person, and so have you evaluated how usable they are for the person, if they are really comfortable or not, or if it's worth? So which difficulties could have this in the real practice with the usability or the comfort of the patient?
Yeah, okay, as far as I know, what they are doing now are monitoring sessions of 24 hours. And for this period, it is okay for the users. They like the system because they think it can be really useful for them in order to a doctor that can assess the disease. They will be trying to extend this period of time to see how usable it is. The thing is that the sensors are not heavy at all, but it is true that you have to wear lots of things. So in a further prototype, they will try to lower the size of the sensors.
And the patients, when they're wearing it, they have to do the normal life.
Yes, it depended on the phase of the pilots. Some of them were just to collect data, so they just want to go and then they have to do the normal lives.
Someone else has any question? Yes.
The user interface is beautiful, or what platform it is used on?
I have no idea. I'm sorry, I cannot answer your question. You can contact my colleague because this is something that I really didn't ask him. Sorry.